Hello and welcome back to the Oncology Brothers podcast. I'm Rohit Gosain, and I'm here with my brother and co-host Rahul Gosain. In our ongoing series of challenging cases, we continue our journey with non-malignant hematology, and today we'll be focusing on the most common referral that we see in our practice, that is iron abnormality, whether it's deficiency or overload. These cases are managed by multiple specialties and even general medicine, so certainly an important topic to cover here. Let's touch on some of the common scenarios that we run into. And to walk us through these cases, we're joined by Dr. Marina Beltrami from The Ohio State University. Marina, thanks so much for joining us.
Marina, welcome. Over the next few minutes, we'll touch on three scenarios. Starting off with anemia in pregnancy, then we'll switch gears to anemia with a mixed picture, and then to close off, we'll touch on iron overload case. Let's start off with our first case here, where we have a 34-year-old woman in her second trimester of pregnancy referred to you for low MCV of 75, low ferritin of 4, and her hemoglobin is 9.5. She has ongoing symptoms of fatigue. Marina, for this patient, what options do we have? Is IV iron safe in second trimester? What about IV iron in first trimester? And given her symptoms and these labs, should oral iron be even considered?
I tend to be very aggressive for repleting the iron, and after we're past the 14 weeks of pregnancy, I typically go for IV iron, especially in this patient that is already experiencing significant anemia. And the other symptoms which will improve likely even more promptly than the levels of hemoglobin, such as the fatigue, the concentration, the memory problems, etc. I think oral iron, it's almost always a good option. I think there are subtleties about doing that in pregnancy, especially with some of the additional physiological changes that happen, such as constipation. And I tend to get creative with using alternative formulations of oral iron that have lower concentrations that are gentler on the stomach, anything between 18 milligrams of iron to 65 milligrams of ferrous sulfate. But for this particular patient, I would go for IV iron. IV iron is very safe during pregnancy. The two preferred formulations are Venofer and Ferritin. They have the most robust data in pregnancy. Ferritin, you could give about 500 milligrams of iron in a single infusion, which is very convenient. The rate of infusion reactions with that is very low. So that's definitely a preferred one. In my practice, if it's not an option, then I use Vena very liberally, but I don't give Vena for more than 200 milligrams in a single infusion, because past the 200 milligrams, you start seeing more of those infusion reactions. I tell patients we'll make it a short visit to the infusion center. It's a 5-minute push. They come a few times into the infusion center, but at least you can get some iron with a very low risk of infusion reactions.
Thanks so much for covering all that. With regards to 18 to 65 milligrams of elemental iron that's administered, are you administering this daily or every other day, as we have seen from recent studies?
I typically just have a conversation with the patient. I'm happy that they do either daily or every other day, certainly not more often than daily. For some patients, it's difficult to remember a schedule that is not steady, and I think there's nothing wrong with taking it daily. It's more just about the tolerability and how you can make people remember to take their tablet.
Certainly. And with regards to infusion reactions, if encountered in second or third trimester, if they are to have hypersensory reaction, what medications are you relying on? So how do you sort of combat that?
I don't think there is an absolute contraindication to using diphenhydramine if there is a true anaphylaxis reaction that you're concerned about. The question is always trying to tease those out when somebody's starting to have back pain in the infusion center. I think we have intravenous formulations of more selective second generation antihistamines coming up. Sometimes, if there's a particular concern for the patient, you can still use the oral second generation antihistamines. But of course, in the case of a true anaphylactic reaction, we do what we have to do.
Certainly.
I don't typically pre-medicate patients routinely, though.
Okay. And when would you check these labs? Again, repeat them in about 6 to 8 weeks' time?
We don't expect to see any significant change in the hemoglobin in less than 2 weeks to give it time to kick in. But I try to, since the pregnancy is a relatively short period and going to be aggressive, I would recheck in about 4 weeks, make sure that we're going on the right direction. And even before I start the iron infusion, I make an estimate of how much iron gap is here that we need to address and try to be aggressive in giving that up front.
Can I reiterate a few things here? When we're talking about Vinifer 200 versus 300 or 400, the infusion reaction is dose dependent. So out in the clinic, we have to be careful with that. Marina, any infusion related reactions with push versus IV at that 200 milligram?
Not that I'm aware of. It's pretty standard in our practice, in our infusion center, that the 200 milligrams go over 5 minutes, and I rarely, if ever, saw a reaction to that.
All right, moving to our second case, we have a 78-year-old man with hypertension, a history of prostate cancer, currently on single agent Lupron with good disease control. He also has history of diabetes and CKD, chronic kidney disease stage 3. He reports ongoing fatigue and widespread joint pain from his underlying arthritis. Labs are consistent with elevated ferritin of 450, low transferrin saturation, and hemoglobin of 9.2. MCV is normal at 89. In this case, Marina, what would be your broad differential and treatment options?
Yes, this is a very broad differential, and more often than not, there is more than one factor playing into this. So just unpacking this case a little bit, just based out of his age, anemia is very, very common in older adults, and iron deficiency anemia is the most common etiology. Definitely something that I keep in my differential, even though the ferritin is very high. Whenever I see a ferritin, especially if it's less than 100, but anything less than 200 with a low transfer saturation, I will think about other risk factors like chronic anticoagulation or a history of GI bleeding that could put this person at risk of having an unrecognized iron deficiency. With the history of prostate cancer, it's possible that this person is on some kind of anti-testosterone therapy or testosterone lowering therapy. Lower testosterone is also a driver of anemia, although typically milder in the 11 to 12 range. The chronic kidney disease, it's not clear at what level of EGFR necessarily you can attribute the anemia to the CKD. Sometimes there's a little bit of a disconnect with the endocrine insufficiency from the kidney with the filtration insufficiency. That's certainly not helping the picture here. Factor also related to the prostate cancer is that oftentimes men receive pelvic radiation, which is a relatively higher risk of being associated with secondary hematologic malignancies. So potential chemotherapy and radiation exposure, advanced age, certainly a bone marrow failure syndrome like MDS, malignant disorder is in the differential, as is other hematological malignancies, but less high on my differential. I wouldn't necessarily go straight to recommending endoscopies and colonoscopies until I have some evidence that there is bleeding going on. And so sometimes what I will do is try, if they respond, I'll say, you're bleeding. You're going to have to figure out where this is coming from. At this level of hemoglobin, the 9 to 10 range or even more severe, I would have a discussion up front about getting a bone marrow biopsy since the severity of this anemia. If this patient is not dialysis dependent on, has severe CKD, even if you say that CKD is driving it, it becomes tricky to use tight stimulating agents. We have a higher risk of causing thrombosis at a lower hemoglobin threshold compared to dialysis patients. Try to comfort yourself and the patient saying that's the driver of the anemia, but unfortunately, a little bit more difficult to act on. Now, just going back to the point about the primary bone marrow disorder and the risk factors for secondary myeloid malignancies, depending on the patient's preferences and their level of concerns and symptoms, if they are reluctant about pursuing the bone marrow biopsy, I will oftentimes offer molecular studies from the peripheral blood, so namely some kind of myeloid molecular panel. And what I explain to them is that it's not a definitive diagnosis, but it will help us risk stratify what is the likelihood that we're going to find something abnormal in the bone marrow itself. If you are in the range of low risk MDS, there are treatment options that can help support the anemia, treat the anemia, and support symptoms. And you're in the higher risk MDS or even acute leukemia spectrum, they can certainly at the very least inform prognosis and even open some opportunities for treatment as well. So I would definitely have a discussion about a bone marrow biopsy with this patient at this level of anemia.
Thanks for covering that, Marina. With regards to NGS panel, that can give us some idea from the molecular testing standpoint. Often we would see that when we have ordered flow cytometry, that would come back normal, but the NGS panel will tell us about ASXL1 mutation or DNMT3A, which are associated with MDS. Would you rather go down that route or initially get correction on the iron panel and see if erythropoietin stimulating agents are adding any benefit, or rely on bone marrow biopsy route?
Yeah, I would. I'm very concerned about using ESAs in patients that are not on dialysis. I would rather have a confirmation of a diagnosis of MDS that will justify using an ESA before trying that. I think it's very reasonable to try a round of IV iron and see if they will respond, especially depending on the patient's acceptability of a bone marrow biopsy. But again, at this level, I would have a very low threshold because oftentimes it's more than one thing contributing to the anemia.
Indeed. And as you stated with dialysis, if this patient was dependent on dialysis, but also with history of cancer, we have been shying away from the use of erythropoietin stimulating agents in those settings.
Yeah, I think if you've optimized everything else, their iron saturation is at the level that is appropriate for a dialysis patient, and you've rolled out that there are other primary bone marrow disorders, I think it becomes a risk benefit conversation with the patient. If we think that the anemia is a main driver of their fatigue, which is in itself a very complex symptom, as you know very well, I think it's an informed discussion we have with the patient, and I will do what I have to support their quality of life if that's consistent with what they want.
When we're talking about ESAs, of course, the risk of that malignancy, also increased risk of blood clots and hypertension. These are the things that we're talking about back and forth when we are leaning into ESAs with our patients.
Rahul and Marina, that's right. What we are seeing here is a mixed picture. That is chronic kidney disease, anemia of inflammation, and degree of iron deficiency as well. Now, looking at this particular case, we are seeing is a 47-year-old female who's coming in being overweight, diabetes history, where this polycythemia seems to be concerning secondary to obstructive sleep apnea. Her ferritin is also high, but for this conversation, let's assume that we did test her for hemochromatosis and was found to be heterozygous for C2A2Y mutation. Marina, for this particular case, over the next few minutes, can you please touch on a broad differential for elevated ferritin when homozygous mutation for hemochromatosis has been ruled out? And importantly, any role of phlebotomy here?
Yeah, that's a tough argument to make. So she has very, very elevated ferritin, which could be part of a reaction apart from the chronic inflammation that she suffers from. But to me, the main key here is this transferrin saturation of 47%. This is more than I would expect for an anemia of inflammation type of picture. And yes, the risk of having chronic iron overload with a heterozygous phenotype is very low. So in this patient, I might actually reach out for a liver MRI to help us estimate the actual iron deposition and clarify how much is reaction, how much is true iron overload. And might needs to get creative in terms of even consider an extended hemochromatosis genetic panel testing to see if there's anything else that we might be missing here, because not expected for a heterozygous HFE mutation in a fairly young woman to have this type of iron panel picture. I'm very hesitant to use phlebotomies in patients that don't have a clear diagnosis that would justify doing so, meaning primary polycythemia vera and hereditary hemochromatosis or a secondary hemochromatosis. I would reach out for the liver imaging to help inform the discussion.
Marina, can I take a deeper dive on this? A patient where you don't have a clear cause, let's say heterozygous hemochromatosis, you get that liver MRI and there's higher iron deposition. What number are you chasing in that scenario with phlebotomy? Because when you have clear-cut case, we're often being more aggressive, saying your ferritin should be less than 100, ideally even less than 50. In a case like this, how far are you pushing? Also, is there any role of echo in these patients?
Yeah, let me start with the second question. So in our institution, we're lucky to be able to order a combined liver cardiac MRI that will give me the quantification for both. Certainly, if we're seeing iron overload in the heart, it's very concerning, and I'm probably not going to waste too much of my time before into this and exactly what driving it and start the phlebotomies. If it's just in the liver, I'm gonna consider phlebotomies if you have more than 4. I might miss the unit here, but I think it's 4 milligrams per gram of dry weight of liver, which is consistent with what we do in thalassemia, for example, and consider the phlebotomy. The ferritin number, it becomes definitely challenging, right? Because it might not be reflective of her true iron stores with all the inflammation. I think what I use oftentimes is what the hemoglobin is doing. If I'm pushing her into the normal range or anemia range, then I know that she's definitely depleted.
Now, if this patient is not heterozygous for hemochromatosis and you've ruled out any genetic causes related to this, are you going to phlebotomize these patients with higher hemoglobin just because they have higher hemoglobin?
No, I think that's an excellent point. I think we need to dissociate the iron overload from the hemoglobin because even patients that have hemochromatosis with tons of iron will not become polycythemic unless they have an additional driver, be that sleep apnea or some other cause of secondary elevation of erythrocyte, or they have JAK2 mutation or another MPN. I would definitely make sure that we have a clear diagnosis for this polycythemia. If it's secondary, I'll try to address that because it has its own risk, for example, with the obstructive sleep apnea, with the cardiovascular risk and whatnot. But I think for this patient, I would only do phlebotomies in 2 situations. One, I have tissue evidence of iron overload, even if I can't completely put my finger on what's driving it. And 2, if she has either PV or secondary erythrocytosis, but is very symptomatic of that, and patients who often complains of like brain fogginess or feeling sluggish or just they have all sorts of a little bit not specific feelings, but then you give them a phlebotomy and it's like, wow, I'm a whole new person. But I still send them and make them wear the HIPAA and hopefully stop the phlebotomies once they are that's better controlled.
And sometimes we see a mixed picture of obstructive sleep apnea, hemochromatosis, and when we are too aggressive with their phlebotomy, we rather make them iron deficient. Now, are you chasing where you're actually giving them iron to assist with the fatigue or dyspnea they might be having?
I just really try to avoid making them iron deficient. I've had patients whom we gave them a little bit of oral iron. This is a case of secondary erythrocytosis. We gave them a little bit of their iron back because they were getting symptomatic from the deficiency. And in the meantime, we're trying to get him to lose weight and treat his sleep apnea and all of those things above. Because, yeah, I don't think there is ever a good justification to causing iron deficiency, especially to the point of making people asymptomatic.
Marina, can I touch a little more on the same topic? Secondary erythrocytosis, you've ruled out MPN here. Let's say there is an obvious cause of obstructive sleep apnea or hormonal replacement, testosterone. Is there a magic number of hematocrit? Should it be less than 55, or are you strictly chasing the symptom?
I am not aware of a magic number for secondary polycythemia that we should be looking for, especially for women with a kind of similar thresholds that you would use for polycythemia. You start worrying about their risk of thrombosis. I am very persistent in trying to find what's driving the secondary angiogenesis and make sure they got liver imaging, renal imaging with Dopplers, ruling out renal artery stenosis and masses that could be producing hormones ectopically. Because ultimately, the phlebotomies in these situations are just to make the numbers look better. We should really try to be focusing on the main driver of the secondary erythrocytosis.
Absolutely. You bring up a good point. Things like RCC, underlying kidney cancer, can have a paraneoplastic syndrome where you are seeing this erythrocytosis. So that workup is important. Marina, any final thoughts or clinical pearls for our primary care physicians or community oncologists seeing these patients?
There's always iron deficiency until proven otherwise. And getting that full iron panel is extremely important, both when you're looking at low ferritin levels or suspicion for iron deficiency, as well as suspicion for iron overload, because that transferring saturation is so important to be able to understand what's driving what.
And in fact, what we are seeing is more and more we are diagnosing, unfortunately, young people with cancer diagnosis, particularly GI. So whenever we are seeing iron deficiency, we used to label any young female with menorrhagia. But again, it is important to do that extensive lab work while keeping a broad differential in mind and then supporting these patients through right intervention is extremely critical. Marina, thank you so much for walking us through these challenging cases that we see commonly in our practice. For our listeners, let us go over a quick recap from today's discussion. Today's episode with Dr. Marina Beltrami from the Ohio State University was packed with practical cases, including anemia during pregnancy, and then we touched on anemia due to multiple different factors, that is CKD and iron deficiency. And then to close off, we touched on iron overload scenario.
Rohit, something that we readily do is not just focus on ferritin, but rather look at the whole iron panel, and then matching this in the right clinical context for our patient is important. During this discussion, we also touched on a few nuances based on different formulations of IV iron and associated infusion reaction. We also touched on the role of erythropoietin stimulating agents in CKD.
Indeed, what we have to be mindful with erythropoietin stimulating agents is the side effects profile, that is active malignancy, hypertension, and as Dr. Beltrami stated, to rely on them mainly when the patient is on dialysis. Thank you all for joining us. Make sure to check out our other discussions and conversations with regards to treatment algorithms, conference highlights, and FDA approvals. We are the Oncology Brothers.